Hi, my name is James Pearson. I'm with Medic Ambulance Service. We're the exclusive operator for ALS in Solano County. We been operating since 1979. We're CAS accredited, ACE accredited, operate about 45,000 calls a year. We travel about 1.6 million miles, all that fun stuff. But we're good. Solano County is about 450,000 people, and this is where our pilot is. We're lucky pilot site 13. So why did we get involved with the MIH community paramedic programs? Obviously, it's been talked about nationally for the last 3 to 4 years. It is going to be the way of the future of how we provide services. It can separate you, your organization. We wanted to be a leader. We are a leader, we feel, and we want to. This opportunity can help our county and our citizens. It does impact the community. The services you provide, especially in these types of programs, you outreach your patients, and it helps you be a leader in healthcare in your community. So this is actually, there was a survey done by AMR, Envision, and NAEMT. And they surveyed all the pilot sites or MIH programs from around the country, and this is why people gave their reasons for starting the programs. I thought it was just good information. Was there a gap analysis, a community assessment, or did they just do it to do it? So I just thought it was a good slide. So we were actually approached by the Kaiser Permanente group in our area in 2013, as Dr. Backer said, not too short, pretty long ago. We needed local EMSA approval. Our county wanted us to also invite all our local hospitals to see if there was interest. So we reached out to North Bay, and we have a North Bay Healthcare Group, who I'll talk about a little later, and Sutter Healthcare is also in our county. North Bay and Kaiser initially confirmed, and obviously with Solano EMS approval, we move forward. We established a steering committee, which was a mandate, but it's also important to keep the communication. We meet monthly and have since 2013. One of the big goals was to try and build a sustainable model. And I loved hearing Sandra say sustainability, because that was a big deal for us. We can spend 3 years, 4 years into this, but if we don't have some form of a funding model, we don't have that discussion, which is a very hard discussion up front, it could all fall apart at the end of this pilot. So that's one thing I could say about our pilot and our partners, is we actually have a funding model, which is exciting. The two main goals, though, of our pilot is to reduce readmission rates of CHF and COPD from a 30-day admit, and obviously improve overall health of our patients. Those were our two measures. So right now we have one member. It's North Bay Healthcare. They're a level 2 ACS verified trauma center. They're also a STEMI receiving. They have the full gamut. I mean, we all work in EMS. They do everything in our county, as well as Kaiser, but North Bay is the partner in the pilot. And they manage a lot of Western Health Advantage patients in Solano County. We have a lot of those patients. So one of the big things we talked about was value. I had somebody ask the question of, do people cross? I heard that question of cross, can this pilot look at this? There's a lot of programs going on with post-discharge that aren't community paramedic based. We have a transitions program that our local partnership health plan's working on. So one of the big things that our hospital approached us out and told us is they wanted to measure value. North Bay Healthcare has also a complex case management program where they work with their high utilizing CHF. One thing that if you guys are having these discussions with your hospitals, you'll see they don't have the resources. North Bay didn't have enough resources. But one thing we didn't want, or our hospital didn't want, is they didn't want us double touching. They wanted to see the value of this program. At first, we were a little skeptical about it because it wasn't really in how we drafted the pilot. But in the long term, it's actually proved to be very beneficial because, as you'll see when we get to the results, we're able to measure an amazing value, and actually that's a near landslide compared to what their current programs are doing. We wanted to track and trend everything. I think that's a big thing. Going to different conferences, the community, our group that we work with, dealing with UCSF, measuring is key. We actually signed also with EMS Survey Team. I don't know if anybody knows who that is, but they're a third-party patient satisfaction service. So all of our community paramedics actually, once they disenroll with the program, they get an actual phone call from EMS survey team, and then we can measure actual patient satisfaction as well. That's not being done by us. So that was a big deal for us. We have weekly case management team reviews with our group, and we have monthly reviews with the North Bay group as well. So, get into the fun stuff. Here's our results. So, we started September 15th. We were not an overachiever and started June 1st. We had IRB issues. We had to, if anybody's ever done IRB, this is the first time our team had ever gone through one. They're great once you've learned through them, but it's hard to go through. But good process. So we've had 91 patients so far referred to the program. 66 have been enrolled. 38 were heart failure, and 28 were COPD. One thing I will say, somebody asked us to talk about why we see refusals. It runs the gamut. People want to get out of the hospital. They don't want anybody else in their house. They don't really understand the program. We've worked with North Bay we've had local media that'll kind of show you that we now have articles in the packet to help get that information out so patients aren't as reluctant to join the program, because it is a new service. And one of the big things we did notice too is when I was talking about that transitions program from our partnership health plan, at first we learned that they're actually being offered kind of one or the other. So that had to stop. So they weren't being offered this, was it a PA in the home or a paramedic? So people were saying, oh, I'll take the physician assistant over the community paramedic. We caught that really quick and ended that kind of offering. So they identified and only offered one service and didn't let the patient choose. So we've done 124 total visits to date. And actually, I think we've had since, so this is about 2 weeks older data, but up to about 2 weeks ago. We've had only 6 unplanned readmissions. We worked with UCSF, so we have one patient who was a planned readmission. At the 27-day point, their doctor called them and said, hey, we need to move your mitral valve replacement surgery up. I mean, that is a readmit, but we want them to have a better heart, right? I mean, the goal is to keep them healthy, so if they readmit, they readmit. We don't say, hey, wait 3 more days and let's keep them out of the 30-day window, right? But one of the cool things that I think you saw earlier was with the diagnosis and not with the diagnosis, 4 of the 6 patients were readmitted with pneumonia. So we're working with the hospital right now to kind of identify, those triggers, because there may be earlier signs we can get with their team and notice that. 3, actually a good even split though, 3 males and 3 females. So, I mean, any questions on, sorry, we'll do later. Sorry, no questions now. But we have the unplanned readmit rate is a 9.1%. So if you threw that extra 1% in there, I think we go to 12% readmit rate. So the patients that refused our service that stayed in the North Bay and all the other North Bay complex case management programs, they have a 22 to 25% kind of over this last 6-7 months. That's their rolling readmit rate. So North Bay is very impressed so far with the program. This is some other key data when I say we track and trend everything. 86% of the patients had their visit take place in the home. So 15% of our patients we've actually seen on the street. We've seen them at a Burger King parking lot. If they're homeless, we can still take homeless patients, so it's not an excluder. That's actually 52% because we just went over some data yesterday that I did not send Lou the updated slides, and I wasn't going to mess with the slides. But 52% of our patients had medication errors. So, and the funny thing is when we survey them too, 92% of them think that they understand their medications and everything's good with their medications. So they think they're good, but when we get in the home, 52% of them had a medication error. And they run the gamut. This pill's in this bottle, and then they got the resupply. They lost the bottle, so they put this med, the lisinopril, and the atenolol bottle, but they know the lisinopril's and atenolol. Believe me, we've heard it all. And you see it all because it happens in the home. Or even on the street, like I said, the street corner. Our average visit length is 109 minutes. Our longest visit was 181 minutes. Our first visit ever was like 3 hours. Obviously, we can't do 3-hour visits, but we're learning. Our first visits tend to run long. We do a home assessment. We spend a lot of time on the consent form on that first visit. There's just a good interaction. Our second, third, subsequent visits, we've been able to really kind of get them down to a good time frame. We do a health assessment, a national health survey. It's a 5Q, 3D, 5L. We actually learned it from MedStar on how they survey their patients to get an overall health assessment. That number is actually up to 22%. And we survey them at every visit point from the first visit to the last visit, and they rate their health score. So it's measured from the first interaction to the end interaction. So that's, our patients are getting healthier. Another big thing, or feeling healthier at least. Their discharge, they also understand their discharge instructions. We give them the same discharge questionnaire on the first visit that they get on the last visit. And as I said earlier, we work with North Bay, so we present as a healthcare team on these. So it's actually a benefit to the hospitals because it's showing their patients that they understand their discharge instructions a little bit better. And so this is what an EMS survey team looks like. It's actually a great report. It's about, for our community paramedic system, it's about a 30-page report. Gives you very good detail, very good feedback. But just to give you some good numbers, 96% is an average score that we get from the patients. 85% of the patients that responded had rated our medics as very good, and 100% of responses were positive. We also use our 911 system in Solano County and Sacramento. We use this system. It's a different, little bit detailed questions, but our community paramedics rate about 3 to 4% higher than our regular 911 paramedics. The lowest score, I think one of them is like 96. So the patients really engage with our community paramedics. We hear that from our CPs. We hear it from our patients. They love our paramedics. I know these guys are going to probably say the same thing. It's a totally different experience for our paramedics. This is just some local press. This was our local Fairfield paper. This is one of our first patients we had. This is another one in the local Vallejo paper. Just kind of give you that, and these patients were more than willing. They wanted to be a part of it. They wanted to talk about the program. They loved it. This was EMS1, the national news website service. We have a video. If you go to Medic Ambulance, just do Medic Ambulance Community Paramedic Program on YouTube. You can see this video. It's about a 9-minute video. We have talk about how our program works and some testimonials. Same article. So just some quick results. We celebrated a lot of our early wins. We still have a lot of wins, and those celebrations, getting them in the media, we want to bring our other partners to the table as well. Patients are very happy and satisfied with the service they're receiving from our community paramedics, which is a big measure for us and for the future if this works for our patients. After 30 days, so one of the quick things I'll say is when we first started this, North Bay said, hey, let's just start with heart failure for 30 days. Let's just see how it goes, and then we'll slowly add in COPD. After 30 days in this pilot, they said, we want it now. Well, let's add CHF. Let's add what can't you do? Is something they actually said about 5 months ago. They said, we want everything you can do. We said, well, we're just doing these two for now, and hopefully we can change that later. We've been in negotiations with Kaiser to add them to our team, and we're actually in negotiations right now with Sutter to get them into the mix as well. So a lot of good stuff, a lot of good results. It's engaging for the hospitals, and that's all I got. I'll move on.
My name is Neil Klein. I'm a registered nurse at Enloe Medical Center. I'm also the assistant chief of, don't put that there, of Butte County EMS. Just go ahead. So I'm also the project manager for our pilot program at Enloe Medical Center in Butte County. Butte County has a population of around 250,000 people. 4 hospitals. Enloe Medical Center is the level 2 trauma center, STEMI receiving center, stroke receiving center, and pretty much the hub of medical care for our county. Funding for our project, there was some grant money available to us, but we weren't able to accept it due to some tax reasons for our nonprofit status. So We are financed, but we're not funded. The hospital and the ambulance programs are picking up the tab for all of our CPs. So when I wrote this proposal for this, I tried to keep it narrowly focused because even though we only have 4 hospitals in the county, cooperation and a misunderstanding of EMTALA rules and HIPAA violations may not be clear to everybody. So we kept it narrowly focused. Our criteria for inclusion, we chose heart failure and acute MI discharge readmission to try and prevent that, because I'm also deeply ingrained in that as the STEMI manager for Enloe Medical Center and into the cardiovascular program that we have there. So our criteria for inclusion into our program was, first you had to be discharged from medical center, because I'm deeply ingrained there. Next, you had to live in Butte County, because we weren't going to go outside of county. Butte County is fairly large and has a very significant rural population, and some places are just simply difficult to get to. You need to be discharged to home. You couldn't be going to a SNF. You couldn't be going to a rehab. You actually had to be healthy enough to be discharged back to home, and that way we could monitor your health there to try and get you back in without the other resources that may be available to you in the SNF or in a rehab center. You need to have the consent signed, and we would attempt to contact you within 72 hours. My personal experience was that if you tried to get hold of patients who were recently discharged from the hospital in the first 24 hours, they either weren't interested, or they weren't listening, or they were just too overwhelmed by their whole hospital experience to really appreciate what you're trying to do for them. So we are a joint venture between a hospital-based ambulance program out of Enloe Medical Center and a for-profit ambulance service called First Responder, and together we make up Butte County EMS. We started off with 10 community paramedics enrolled in our didactic project, 5 from each of the respective programs, and now we've narrowed that down to pretty much 3 dedicated community paramedics, 3 who come in part-time, and then 4 who really aren't involved at all now because of their other duties that they have to do with the respective ambulance programs. We didn't start this model off with dedicated people out to do it 24/7, which what we originally wanted. We just simply couldn't do it that way. So we tried to dovetail this project into the rest of their duties, and found that it was just pretty much overwhelming. It is a lot of work. So we narrowed it down to just these few people who they do their regular duties, but they're also allotted 6 to 10 hours of overtime to come in and fulfill the needs of this project. So our process is really kind of complicated. We are, like I said, just out of Enloe Medical Center. They have to be discharged from there because I can control that and get the information that we need. So I have the discharge planners and the cardiac rehab nurses. So they generate a list from the patients who are discharged with a specific diagnosis of acute MI or heart failure. And with that discharge diagnosis, they give us a spreadsheet, and every day the medics will check that list to see who's been discharged, and the list is generated that has everybody on it, and then those that have been discharged are timed out, and then that's when we start our 72-hour clock to make contact with them. Like I said, if they're contact too soon, they really are pretty much overwhelmed, especially the patients that have had acute MIs, because they have just had a life-changing experience and really have to get their head around what the rest of their life is going to be like, with diet changes and exercise regimes, and it's really a lot for them to take in. So we give them a break to settle themselves in at home before we contact them and try and arrange a home visit for them. What we use is we start off with a telephone contact. We use what we call a stoplight algorithm, green, yellow, and red, where green being we just do a basic health assessment with them. We try and figure out what their state of health is, how was their hospital experience, what things have changed for them. Do they understand their medications? Are they taking their medications? Do they have a 30-day supply of their medications? We'll try and do a med reconciliation over the phone. Sometimes that works. Sometimes that's enough to push them into the yellow. Or if they're just not feeling good, we'll push them into the yellow, and then that will initiate a home visit. We'll try and make an appointment, try and get out there that same day. Sometimes that doesn't work for them. Either they'll have a doctor's appointment or they just don't want you to come in at that point. But we'll make a home visit appointment with them right away to try and get them to do what we do at a home visit. And if they are in the red, they're having chest pain, they are short of breath, or we just get an inclination that they really need some extra support at that time, we'll either send the community paramedic out there right away or simply send a 911 ambulance out there to check on them. And so that's pretty much for our algorithm. So at a home visit, when they do show up there, they do take quite a bit of time. First, the medics will research their medical record again to find out what may be a cause of having some difficulties there. Then they'll do, when they arrive at the home, introduce themselves. They'll do a quick safety survey of the home, make sure there's no trip hazards, make sure that their home is safe. If they're not always clean, that's not what they're looking for, just to make sure that they have access to their meds and whatever else they need. They'll do their med reconciliation at that time, and like Jimmy said and was stated before, this can be the difference between coming into the hospital right away or keeping them out for the 30 days. We try and solve any medical problems that they have now, that they have immediately, that prompted the visit. We have online medical control. We have access to their private physicians, to their cardiologists. Whatever it is that they need, we try and solve that immediately. A lot of the patients that we do go out and visit, especially the heart failure patients, they don't even have a scale at their home. So we, through a grant through the Emergency Nurses Association, they've given us money. So if they don't have a bathroom scale to weigh themselves daily, we provide them to them. If they don't have a BP cuff, we'll give that to them also. We've given out more than 30 BP cuffs, more than 15 scales, and 2 bariatric scales that are actually talking scales because they can't see the numbers on the scale. So as a result, so far eligible patients that could be enrolled in a program, 682. Because like I said, we take all comers. If they have a discharge diagnosis of heart failure or MI, they go on our list. So there's been 682 so far that have been eligible. Of that, the ones that have consented have been 512. We've had 141 decline for various reasons, whether they're not necessarily discharged to home because they don't have a home to go to, or they simply don't feel like they want that follow-up help. 475 contacts. Like I said, I guess we gave over 20 scales, 30 BP cuffs, 62 home visits. And what we found is the patients who were eligible that weren't enrolled, their emergency room visits after 33 days is right around 36%. We've had 51 of the 162 who have declined have all had an ER visit within that 30 days. And the ones who were enrolled is only at 10%. And for readmissions, if you were eligible but weren't enrolled, 36% wind up being readmitted as opposed to 12% if they are enrolled in the program. So I don't have a slideshow because we are in Northern California, and for those that you don't know, California does extend beyond the Bay Area and San Francisco and Sacramento, but our computers are still made of wood. So thank you.
I'm Steve Rotman. I'm an emergency physician on the faculty at UCLA and was the PI for this project that we did with our group, with the City of Glendale Fire Department, LA County EMS, and Glendale Adventist Hospital. Let me tell you a little bit about what we were working with here. Glendale's got a population of maybe a couple 100,000 people. I'm looking at my colleagues who will tell me this. And Glendale Adventist is one of the 3 hospitals in the community and has a bed capacity of a little over 500, I would say. Yes? Yes, the heads are nodding yes. And so the Glendale Adventist Medical Center partnered with us and the fire department to look at a project specifically geared to try to keep heart failure patients from being readmitted within a month of discharge. The rationale is pretty much the same as everybody else's. The readmission rate nationally is about 25% within a month. These patients are fragile and they deserve better. And this is what we all went to school and work for, is to try to make ends better for patients. So it's suboptimal for their well-being. It results in more 911 calls, people coming to crowded emergency departments, increased wall time for the medics, unavailable bed capacity upstairs, all of the cascade of things that happen when people need to be readmitted to the hospital for conditions that if we were good at, we might be able to keep them out of the hospital. Plus, this is the fun part, the economic costs to either insurers or Medicare, and then the Medicare penalties that are imposed on the hospitals, which makes it even more complicated. When we submitted this proposal way back when, we were looking at numbers that were about 400 admissions for heart failure a year in this particular hospital, with a readmission rate of about 24%. So it was pretty much right at the national average. The project looked something like this. We trained 3 Glendale firefighter paramedics specifically in what our protocols were going to be for evaluating and managing patients with heart failure. So after they finished the core curriculum, they had to put up with me in the hospital for another 8.5 days to really immerse themselves in cardiovascular physiology, pharmacology, physical examination findings, all the parameters that we could use. We reviewed more details about EKG reading because they were going to take electrocardiograms at the patients' homes. They spent some time looking at echocardiograms so they could have visual images of what hearts look like when they're functioning and when they're failing, so they could try to really make this tangible for them. And a fair amount of time on pharmacological management, which is a common theme, I think, for all of us right now. The fire chief at the time and his successor basically said, we will underwrite the support of this program for a year at the cost to our department, which means that they sent their medics to training and then ultimately dwindled it down to one who Baxter Larman calls the poster child for our program, Gil Mejia, who's sitting there and will field questions for us later. And his assignment was basically, you're not a firefighter paramedic and the 911 response anymore. You live in the hospital. This is your program. And he embraced this and basically saw every single patient who had a diagnosis of heart failure in that hospital to review their cases and meet with them and discuss the program of basically coming and visiting with them after they went home. And we, like everybody else, started to look at the sort of 2 to 3 day window because the literature shows that although the readmission rate is high at 30 days, it's higher within the first week, and it's highest within the first 2 to 3 days after you go home. So we wanted to try to make our impact targeted on those most vulnerable periods. The partnership with the Care Transitions Office at the hospital was just terrific. Because they would give Gil a listing every day of who's in the hospital, who with diagnoses of heart failure, and he basically became part of the rounding team. The nurses knew him, the cardiologists knew him. He would meet these patients and sort of follow them during the courses of their care, so that he established a really intimate relationship with the entire team that was taking care of these folks from the time they were admitted until they progressed through their hospitalization and were getting ready to go home. The home visits then were offered to all of these patients, and again, they had to go through the same thing that everybody else. They had to sign a consent and that was approved by the UCLA and the hospital's institutional review board. So we had to go through 2 of these, so that they knew that they were being part of a program that would be evaluating what was going on, and that's pretty much how we did this. Gil would build out a binder on every patient that he saw that would have a summary of their medical record, their medications, their EKGs, because he was going to compare those with the ones he did at the house, their weights, their comorbidities. That could be, my sense was in many ways he might have been the only clinician who saw the entirety of all of what the patient's diagnoses were, because there was a pulmonary doctor and a renal physician and cardiology people. And I often wondered if Gil was the sort of the nidus of all of the different clinicians who were taking care of these folks. He had the discharge planning program with him. He had the game plan for the patients, when they were supposed to come back, and who the contact physicians were. So all that stuff was in his realm on each of these folks. So if we looked at our outcomes, it's interesting because from the time we started this, thinking about this, which was a few years ago, the number of heart failure patients rose from 423 to 601 admissions a year. So this is not anything that's going away, that's for sure. We consented 154 patients out of those. So that's only a 25% hit rate. And some patients felt, no, I'm fine, and my family is here, and I have my doctor, and it's very nice, but I don't want to be a part of it. But basically, of those 154, 107 had home visits. And some patients changed their minds. Some we couldn't reach with the contact information they gave us. Some were sent home, and this is a referral center for the community, and so they were out of bounds. They were places where we couldn't go to track them. Some went to skilled nursing facilities, and our plan was we're going to deal with you in the hospital with your medical care, and we want to see you in your living environment at home. And another thing that we stressed was we really want to have one of your family members at your house when we go there, because there are data that show that integrating the family into the home health care of somebody with a chronic illness is a positive toward keeping them well. We have in Glendale the largest Armenian-speaking population outside of Armenia, and so we wanted translators. And in many cases, we were able to have that happen as well. So these are our data. We had 30-day follow-up on 90 patients at the time I made the slide. We're now at 97 patients. And the numbers are pretty much the same. 8 were readmitted for a heart failure exacerbation out of our 97, which is a readmission rate of 8.25%, which is really low. There was a paper published in the Journal of the American Medical Association a couple of years ago that talked about a 30+% readmission rate for heart failure following an index admission for heart failure. So we like these numbers a lot. And we had 8 patients who were admitted for other causes, a urinary tract infection, things that Medicare will ding you for that are not related to congestive heart failure. They just sort of happen to people. So our overall admission rate as of the data that I got just this morning is about 16.5% for all causes and 8.25% for heart disease and 8.25% for anything else. We like that. So that number really should be 16.5% now. And it's with the readmissions that we had. And if we looked at this, immediately before we started this program, the hospital had done other interventions from the time we conceived of this until the time we started a year ago, and their readmission rate was 21%. So we think that we have saved roughly, well, now many more. We've saved probably 27 readmissions. The Institute for Healthcare Improvement estimates that each readmission for heart failure costs somewhere between $11,000 and $15,000, somewhere in there, because these people are not necessarily just admitted for one day of diuretics. Another patient might wind up in the ICU for a week with much more difficult to stabilize conditions. So I just sort of guesstimated at $11,000, and without Medicare penalties, we would be looking at almost $300,000 of costs saved. Now I know that there's great mysticism about billing and charges and insurance coverage and reimbursement rates and everything else. So we chose this as a benchmark because what goes on otherwise to try to figure out what someone pays for something in a hospital is mystical to me. So that's sort of where we were. What worked for us? The smooth integration of our community paramedic into the hospital team, for sure, and having a dedicated paramedic who owned this program, and he really did. Getting the family members there mattered a lot. being able to have access to home health or the physician directly if you needed something on the spot when you were in the house. And this happened a number of times, and we can speak to that later on during questions if you like. And the commitment from the fire department to say, we're going to have to backfill for this guy because he's not doing our firefighter paramedic job, he's over here. So there were dollars that needed to be spent to cover personnel costs. And the Adventist Research Division made a commitment to buy into this program and allocate personnel resources to go ahead and make this work. We had regular phone conferences every couple of weeks to troubleshoot and go over our data. And, that's how we sort of maintain things. What we learned is that the consent process is long and detailed. You may need translators. They may not be interested. We also learned that the financial and personnel commitment by the fire service agency was substantial. And it was important. Otherwise, we could never have done this. Some patients are just hard to track. We called, and they didn't pick up. And the other thing we learned is that pilot projects can lead to expanded efforts. The research folks at the hospital are now looking at continuing this in some form and starting to look at what other conditions can we try to impact to try to reduce our readmission rate. So with that, I think I'll close and hand it off to our next speaker. Thanks. That's the one I pressed. I don't know if it'll work for you.
Is that one there? No, it didn't. I'm pushing. Oh, there we go. Okay, good morning. I'm Ricky Zombeck, the EMS chief for the City of Alameda Fire Department, and thanks for having us here today. I'd also like to introduce our team, and I'm going to talk about that a little bit in a minute, because actually this is a team effort, and it's not just a fire department team. So with me is our quality, I'll just say our QI and everything else coordinator for the City of Alameda's Fire Department, Dan Gerard, and one of our community paramedics, Armando Baldazan, as well as Elsie Kuzel from Alameda County EMS Agency. And I also want to recognize Fred Claridge, who's formerly with Alameda County EMS Agency and was one of our true champions for our program. In fact, our program wouldn't exist without Fred's help that he provided. Okay, let me have that. So I'm not going to play this clip for you, but I would recommend that if you're interested, that you, and I assume that these slides are going to be available to you, that you take a look at it. It's a local news agency in Oakland, where Alameda's, for those of you that don't know, is an island in the bay. It's right next to Oakland. We work closely with Oakland in a variety of ways, including the Alameda Health Systems group, which is our local hospital. They have 3 hospitals in their system. Ours in the city of Alameda that we're working closely with is Alameda Hospital, and I'll talk a little more about that. This clip's 30 seconds long. I think you'll find it very enlightening. So our program, and I'll mention this right off the bat, the City of Alameda Fire Department has always been very forward-thinking when it comes to EMS. We've been running an ambulance transport service since 1984, ALS service since around 2000. And we heard about this and we thought, well, this makes perfect sense because, this is a way for us to help our community and help the folks that need help. And really that's actually what we're in this about. We know that Alameda, and I'll mention a little bit about Alameda because I think it is important to explain. Alameda is a small community. It's 79,000 people. It's an island, literally, in the bay next to Oakland. It's a well-contained population to pilot something like this. I think we're a good incubator for a small program. You'll see, I'll talk about it in a minute, we have a small number of clients that we've helped, but we've helped them, I think, in a large way. We work very closely with Alameda Health Systems and our local hospital. And in doing that, I think we have a very tightly run ship. I think we get around to serving this population because we work so closely together with the hospital and with Alameda County Health Agency or EMS agency. And as you well know, and we've talked about these goals in the past, we're here to try and improve the system in many ways. Oops. Thanks. No, thanks, Dan. Well, my trusty assistants on the JOB. So we're going to talk just briefly about why Alameda got involved in actually the two pilots. When we come back later, we'll talk about the other one, but the two domains, post-discharge, and there's a reason for that. And then ultimately how we're doing and what lessons we've learned that we can pass on. About 30% of the 9,000 plus folks that went through the Alameda Health Systems organization fit the criteria as we looked at the baseline population. And Alameda Hospital actually does a pretty good job of, with their readmits, they're in at about 11% in the baseline population that we looked at prior to the pilot startup. And I think you would probably agree that's a pretty good number compared to the national averages and some even elsewhere in their member hospitals. Alameda works pretty hard at that, but we've helped them do improve a bit. Oh, and by the way, before we move off this slide, this is another link to another Huffington Post article that a couple of our community paramedics were interviewed in, and it's I think it's another really good media article. And by the way, I should mention that we actually have 5 community paramedics, and we are operating in the city's fire department. Our community paramedics are 2 of them are dedicated to the program at all times. We rotate through so that we keep fresh blood in there. They're energized. Armando, who's here with me today, has been, I think it rotated in about 4 months ago. And I think it keeps the spirit alive. They're working hard, and we do obviously need to have the backup services. It was mentioned earlier, and I would say that as you can imagine, we pulled, or perhaps you can't, but I'll tell you, we pulled line paramedics that had a good deal of experience into the program. So what makes this, I think, very functional in the city of Alameda is that these are folks that have been working with the citizens and with these folks out, whether in the post-discharge or later on we talk about familiar faces. They've been working with these folks already. They know them. They're understood by the population, and I think that makes a big difference. And you'll see that they're welcomed by our groups, our clients. So some of the, one of the things that we're, I'd say, somewhat proud of is the fact that we've reduced Alameda's readmission rate substantially. Now, this is an old number, I will say, and it's actually gone up a bit, and it's still good. But at 2.9%, 2.75% readmission rate is constituted from a small population. We had 109 clients that had gone through the program and 3 readmits. So you can see how the number comes together. We did, and I don't have the updated number in here, but we did have 3 new readmits in the latest quarter, so our number went up a bit. But for full disclosure purposes, I did want to mention that. We're still very proud of that because we're still helping Alameda Hospital manage their patients, and that's the way we see it. We work closely with the hospital and the group of folks over there, and we're a team, and I think that's makes all the difference. We also recognize, and you will find this, and those of you that are operating programs know this, that when you're out there in the field, you're really making a difference with those clients. Armando can attest to this, and I hope you'll ask him some questions during Q&A because he can give you the boots on the ground stuff because he's in the homes, he's talking to the folks on the telephone on a regular basis. He's reconciling meds along with his partner, Pat Corder, who works in the office. We have 2 of them in the office on a daily basis. And they're really making a difference, and we're seeing that. And although this may be somewhat anecdotal, I think that we are definitely making a difference in those folks' lives, and we're proud to say that. But we're doing that because we've established key relationships, and we'll talk a little more about that in the last couple of slides. But those relationships are the critical part of this. We, as a fire department in the community, and we're a department that started in the 1870s, so we've been around for a few years, and we have close relationships, and that's what really makes the difference, because you don't do this, and I'll talk about this in just a minute. You don't do this in a silo. This is really a team effort with the local hospital, your county overhead, your oversight, as well as the agency that's actually doing the work on the ground. And in our case, it's a fire department, and we're right in the trenches out there. So I think that we're uniquely situated. So some of the things that we discovered along the way is, and I'm going to have Dan talk a little more about these things in Q&A, but we know that there's more to do to develop this program going forward. Really look a little deeper into our community's needs, specifically related to this, and maybe an expanded footprint. Risk assessment. One of the things that we found, though, is, as you can imagine, our clients are oftentimes very comfortable, and I say comfortable, maybe they think they're comfortable, but it's hard to move folks off of their level of comfort. So when we come in, sometimes it's difficult to get compliance, or even in some cases to get in the front door, and we recognize that. And we're working hard to figure out the best way to help folks help themselves. But that is one of our challenges. We see it. I'm sure the other programs have seen it. You've heard folks say, well, they've had X number of referrals, and then they've had a lesser number of actual clients that have said okay. And we often think to ourselves, well, why? Why wouldn't you want to accept this free service? We're going to come in and we're going to cater to you, and we're going to help you. We're going to be a concerned third party that's looking out for you. But we know how it is. And we're looking for ways around that. But I do think that one of the things that helps us in our particular program is our citizens recognize the fire department. When we walk in the door, or when we meet them in the hospital, they know us. They know us, maybe not personally, but they know us as an agency. And I think that helps us get in the door. Also, well, let's move on. Some of the things that we know that it takes, and it will take, if you're going to develop a program like this. And we get asked, by the way, by others, how can we do this? And we say, well, you missed the boat for the time being, because this is a pilot. But pull for us, and if it gets authorized, then we'll show you how. And we'd be happy to do that. But we know that it takes collaboration with the local agencies. Our hospital is a very strong partner. We could not do this without that strong partnership, without the partnerships of the other agencies that you see listed, public health and adult protective services, etc. I mean, these are things that we learned along the way. As a fire department, we knew they existed, but we didn't collaborate closely with them because, as you know, many of you in the audience, I see there's some fire service personnel here, you know that we go out and we respond, we deal with the patient, and we move on. But there's a lot more out there beyond when we leave the patient at the hospital, and that's actually where we need to go. We need to go and look at, for example, in Alameda County, we have a number of great services that a lot of folks just don't know about. And we're here to connect folks to those services. When folks come out of post-discharge, there's some things that we can help them with that already exist that they might not otherwise know about. And of course, the hospital social workers work hard to help them with that as well. And we're part of that team. And these are some of the things that we just recognize that it takes. And we have either locally or in the extended area in Alameda County. So these are some of the things that we've recognized along the way. We know that there's a lot more work to do in our group, and it's a small small community, 79,000 people. We know that we don't have the challenges that the big agencies have, but what we do have is we have the opportunity to work in this environment and prove the concept in a small way. And I think then we just have to figure out how to scale it. And I think we can do that. So with that, I'm going to just leave and say that if you'd like to get in contact with us, our contact info is here on the slide. And I hope Lou will provide everybody with copies of these things. But I would encourage you to contact us if you have any questions or need any help. If you're thinking down the road that you'd like to get involved in this after it gets authorized and we move it forward, because it's I think these concepts are they're awesome. It helps us do what we really need to do, which is provide these folks with the services that they need, not just take them to an ER or whatever else. Anyway, thank you.
My name's Miranda Mulholm with the San Bernardino County Fire Department. And like my colleagues here, I'd like to give you a brief overview of our program, some of our numbers, some of our successes, and some of our challenges. I'd like to point out that I do have a couple of our community paramedics here with us. Kevin Dearden from Rialto Fire, John Commander from San Bernardino County Fire, and Kyle Hodecor from San Bernardino County Fire. Our program is a collaboration with San Bernardino County Fire and Rialto Fire and our partner hospitals, Arrowhead Regional Medical Center in the city of Colton. We service residents in the city of Bloomington, Rialto, Fontana, Hesperia, and Victorville. Our target population is patients with CHF that have been discharged from Arrowhead Regional Medical Center. Our goal is to see them 48 to 72 hours post-discharge. We are working closely with 2 case managers in the hospital at Arrowhead that identify these patients on admission. They are actually the ones that are doing the consenting for our program. And once that contact has been made and that consent has been reached, the information is given to me, and I reach out to the patients and we schedule an appointment. Our discharge, our home visit consists of a detailed medical assessment. Our visits last anywhere from 60 to 75 minutes. We do a thorough home inspection. We're looking for safety hazards, trip and fall. We assess to make sure that they have a working smoke detector. If they don't have a smoke detector, we provide them with one. What we have found is that many people have smoke detectors, but they don't have batteries. So we've started stocking our community paramedicine car with batteries, and we provide batteries for these patients. We also do a thorough med rec with these patients. We've found at least 3 med errors on discharge that anecdotally would have resulted in a readmission, so we're very proud of that. We offer support services. We go over diet in detail with these patients. We offer suggestions for low salt, low fat, low cholesterol diet for these patients. And we also go over liquid restrictions with them. We've consented 159 patients to date. We have seen 69. Right off the top, we've identified some patients that haven't met medical inclusion criteria after initially signing the consent. So these patients were discharged to a SNF, they weren't discharged home, or they just didn't meet medical inclusion criteria. We've had a fair number of folks that have changed their mind after signing the initial consent. And I think Dr. Kaufman alluded to this in her presentation. We have a very large population of meth abuse in our county, and I think that the idea of having somebody in a uniform coming to do a home safety inspection with a patient that has struggled with drug abuse in the past has presented some problems. Like I said, we have done 69 visits. Historically, the data that Arrowhead has collected shows a readmission rate from about 14 to 20% for CHF population. I'm very proud of our program to say that our readmission rate is 7. We've had 3 patients readmitted with CHF. We've had 1 patient readmitted for hyponatremia, and we've had 1 patient that we actually had a visit scheduled. He called to cancel his visit and ended up being readmitted. We did see that gentleman after his second readmission, and I'm happy to say that he hasn't been readmitted. Some of the challenges that we've and lessons learned, I suppose that you could say. The hospital that we're partnered with is not on computerized charting. So as you can imagine, when we're talking about data collection with paper charting, that has posed a problem for us. We also have an interesting staffing model. I'm happy to hear that some of these other programs have a paramedic that's designated to the hospital. We actually, our folks see these patients on their day off. They come in off duty and they see these patients, they do the visit, they do all the paperwork, and then they go home. So I'm very proud of our program. I'm very proud of the folks that I've had the opportunity to work with. And after going on so many of these visits, it's very humbling to be allowed into a patient's home, and then the trust that's bestowed with all of these caregivers that are seeing these patients. Thank you.
Okay, we're going to go right into questions.
For the first speaker about the post-discharge, I noticed that the statistics for a patient in understanding the discharge instructions, but when at the beginning and at the end was only a 12% increase. So do you have any idea why you didn't have a larger number of patients who understood after the time you spent with them?
Because before, the funny thing you'll see that we see is when we first meet these patients, they feel they're healthy. They feel they understand their medications. They feel they understood their discharge process. And then they go through an hour-and-a-half visit, 2-hour visit with our community paramedics, and then they go, oh, whoa. But we had already given them that healthcare survey in the beginning. So there's a little, I should have explained that a little better. There's a little bit of a bias there, but at least from there we still see an improvement on discharge instruction. But the patients really live in kind of this box. They think that everything's good, and then they go through the med rec and they're like, oh, the doctor did say that. I didn't know that. And then when they redo that survey, they actually rate it higher. Some of them, I know Brian's here, he's our operations manager on one of our community paramedics. One of his first patients thought they were the only person in the world that had heart failure, and I mean that. So they were very relieved to find out that there's 5.2 million people that have it. But that person rated himself very healthy and understood his discharge. But really, so when he did his survey at the end, he actually rated it worse, right? You see, so it's because he had rated himself so high at the beginning. So you're dealing with some of that data imbalance. So to just see some improvement on that, because to me, the 22% improvement that we see in their overall health improvement with that bias is really big, because, we actually gave them that survey probably at the end of their first visit. It might have been, hindsight, but with our IRB and everything, we didn't change anything. So you don't change IRB, we just keep it nice and straight. So, did that answer your question?
Any more questions?
Thank you. I wonder, when you guys are doing the in-home assessments and evaluations, how many times is that duplicative to somebody else going in and doing an in-home assessment? Were you able to identify that you were in any way repeating what might have been ordered by some other agency to go in there, maybe another 3 days later? And because we find in our super user population that multiple agencies are all trying to help this person, and the patient oftentimes doesn't tell you that. I just wonder if you guys saw that the hospitals had contracts with visiting nurse services or other services that were simultaneously trying to accomplish the same thing.
Yeah, but a lot of times we're a bridge before those services actually take place. Like home health isn't going to show up for at least 3 days post-discharge, most times for a week to get that set up. So we offer that, if we're going to do a home visit, most of the time it's going to be before that home health agency shows up. As far as cardiac rehab goes, they also get that sort of information before that kicks in, which is 6 weeks post-discharge.
You know, and just one other point on that. Some of the things that we were able to do aren't ordinarily done by home health. First of all, not everybody gets home health, so there's a gap. The timing is, as you mentioned, it comes later during what we feel is the more vulnerable period. We do electrocardiograms, and we sort of line those up against what patients had when they left the hospital, and we have discovered patients in sustained ventricular tachycardia, for example, who were not symptomatic but couldn't be left like that, and they, you know, that's a win, you know, for us to be able to do that. And then I think we have been able to prompt home health to come at a certain time and help us line up resources that patients needed that they didn't have with them right at the house, and so this would become a critical period bridge, I think, between the time you go home and the time that the next level of service can be there. I think another thing, just relevant to the first question, is that when patients are barraged with a lot of information at the time of discharge, you know, they're given forms, they're given, here's this, these are your prescriptions, go do this. Do you understand? And they may or may not, but they want out. You know, it's time to go home now. And so much of what happens at the home visit is not only a pharmacologic reconciliation, but an aftercare plan reconciliation to be sure the patient understands what they're supposed to be doing, what their activity level is. We go with different sized bottles to say, how many glasses of this did you drink yesterday versus that, so that we can get some quantification of volume intake for patients, because they, you know, they may be told that you're supposed to track this, but they may have no clue in terms of how to do it. They can't conceptualize it. And it's not critical, it's just life. And I think that that's an important element of what goes into a visit like this, and ours are commonly hour and a half, 2 hours, that you're not going to get somebody at discharge time to sit with you for that time and be sure that you've got that burned in.
I have a question for any of the or all the programs. I think it was Steve that mentioned an element of medical control, and I was curious for these kinds of programs. Did all of you have availability of medical control, of direct medical control, where the paramedic could call from the house and speak to one of the treating physician team? And how well was that accepted, or how well did that work for both the paramedics and for the physicians, since this is a different type of medical control? It's not their base station emergency physician. It might be a cardiology team.
Could I, others of you may want to answer this, but while you do, I wonder if someone could bring a microphone over to Gil Mejia, because he had direct access to this and can tell you more about it. Gil, can you raise your hand? But did you guys have that as well? Yeah.
So the direct contact with the physicians, I always had a face to a name. If I didn't know the cardiologist or the primary care physician from the hospital that I already established contact with, I had a face to the name. So when I would go to the patient's home, and if I did need to contact any of the physicians, I was always privy to that information. And I never had a home visit where I needed an intervention or an opinion from the doctor that I couldn't get a hold of. So it wasn't only one doctor, it was like 5 doctors for some patients. So that was never an issue.
So we've had a couple, and it's another advantage of having a smaller community and total control over everything. That all of our paramedics know all of our emergency room physicians. And so the interactions that we've had on home visits where we did need to make medical contact, you know, the physicians already knew the medic. In one particular case, it was a patient that he had already seen also, so it was easy to give instructions over the phone or through that home visit. That patient did wind up coming in and being treated and released. Some of the other advantages that we have is we can also get some prescriptions filled from the home by calling the patient's private physician or their PA that's taking care of them, and we've had that sort of medical control going on also.
Yeah, we've experienced the same as well. We have a really good relationship with the hospitalists and the PCPs as well. So if we have an issue, we could definitely make a phone call to the office or to the hospital, and it's always proven to be beneficial. We've always avoided a lot of mishap with dealing with our clients, so very well established.
Any,
with the Medicare penalties for readmissions now in their second or third year, it seems like a lot of hospitals are focusing a lot on post-discharge planning and increasing adherence, especially in patients with chronic disease. And so I've heard generally that some of this is happening where folks are going to people's homes and following up and trying to increase adherence. What do you guys think the value add of having a paramedic do this follow-up is over some other health practitioner who might be in allied health or some other phase of care? What is the value add of the paramedic in this role?
So I'll give you some quick info. I think the first thing is that we do these 911 calls. Our paramedics we're doing COP and CHF. I know they're doing MI. I mean, this is what we do, more of a critical setting. So our paramedics have a fundamental knowledge of it. The 8 months of the site-specific, the UCLA training help expand more on that plan of care understanding, social issues. We're not going into the paramedic toolbox for us, right? I think the most thing we've done is given out a nebulizer. We're not giving all these drugs, starting all these IVs, and our readmission rates are good. It's education, being in the home, but being able to talk to them and I loved one of the comments about senior and paramedics, because I know I talk fast, I'm Italian, I use my hands, I talk fast, but we have very senior paramedics, and that's a big deal because they can understand that whole scope of injury. So I think having a paramedic is just, we speak that language and we go in the home. We talk to people in their home already. So it's really been a perfect, mix. Now, again, another conversation we have with our hospitals too is, hey, can you go in that area? Yeah, we do that. We just ran a quadruple shooting there the other day. We're not scared to go in certain areas. We have AVLs, we have radios, we have locators. We have those things that just we do on a normal basis in EMS, that there's no barriers to where we can access our patients. So I just think it's the right lingo, the right education, and it's not really focusing on scope, right? Or I know there's a scope, but focus on what's in the toolbox of just being inside the home is the bigger issue for us.
So short answer is they're more affordable. Okay, nurses have pretty much priced themselves out of the market. PAs, absolutely. It's a underutilized workforce, that there's just a lot of people out there, and they're affordable. The medics can recognize sick versus not sick and make that decision pretty fast. If they are sick, call an ambulance, bring them in. If not, try and take care of them there.
I'd like to add on one thing, too, to what they both said. And I think this is an important point. In fact, it may be the most important point. And in some cases, they can get in the door because they're recognized and they're understood. Some folks can't. Now, we know, and I can tell you because our folks have dealt with it, there are places that some of the other professionals won't go. They won't go in the door. We've been told that. Our folks will, because they always do. They always have. But most importantly, they can get in the door. And if you don't get in the door, you're not going to get anything done. So that's a key point, too.
And I think the other thing that you need to be cognizant of is, you have to look at capabilities and capacities. And I know that, like, your Visiting Nurse Association and Hospice has been doing this for well documented a long period of time, but there's obviously gaps in the system, and there are people that are falling through. What the optimal staffing model is going to look like 10 years down the line, because like right now we're in the Jim Page emergency squad 51 stage, right? And this is like, whatever comes our way we'll take, what I'm saying? Yeah, absolutely. When they first set the program up for paramedics in the state of California, it was just cardiac and trauma. That was the thing. And then there were like, some ER docs said they could do asthma too, right? They can do asthma. Like, yeah, they could do asthma, sure. And they just increased everything that they were doing. What we look at, the model might become a hybrid model at some point down the line. There might be, an opportunity to leverage an NP or a PA somewhere in the program so the community paramedicine people, and probably maybe mobile integrated health is the better terminology, but I'm not going to get into that right now. But maybe the community paramedicine folks turn around and say, hey, listen, rather than try to track down the PMD and try to get him on the phone, I'm going to call up my NP, we're going to get some admission orders, or we're going to make some kind of change here, and we're going to work this in some type of clinical pathway that's already been pre-established. But what the program looks like now and where it's going to be 10 years from now is two totally different things. Like right now, it's like, I don't want to say like it's we're in the pioneer stage right now. We're moving forward. Our only limitation is how far we want to go and how big a claim we want to stake.
Hi, I'm Kathy Stadz, EMS fellow with UCSD. My question was, it sounds like you guys are doing great in terms of medically, socially, you're really achieving a lot of success. What discussions have been made with your agencies about financially continuing after the initial IRBs and grants have run out? How you're going to continue to fund these?
How could you possibly ask a question like that?
Really? It's not about the money.
So I can answer that. That was one of the conversations we had from the very beginning, just because when you go to different national conferences regarding community paramedic, you see these beautiful programs that are out there, and they are beautiful. You spend a lot of time setting them up, but then there's no funding. So we tried to have that discussion with our hospital groups in the very beginning, saying that during the pilot we need to build a model that provides reimbursement to the provider, because they're obviously saving money. And so that's what we've done. We have a fee-for-service model currently right now with our hospital. We get paid out per visit. And the goal right now is to cover the cost. I don't see, again, depending on how many patients, where scope goes, I don't think this is going to be a big money maker or something like that. I think this is a service that you can cover the cost of, though. And that's the biggest piece, because it supplements your 911 system and it makes your patients healthier. But I know people have that uncomfortable discussion about financials, and some people, we'll get to it. Well, for us, it was, we need to have this right up front. We're all out on the table, and so far it's been a good model, and we can expand that. And I know Matt's going to talk. He's got some great stuff of what they do in Texas, and it's going on around the country. But it's a discussion that I would say you have in the very beginning, because there is value for the hospitals in these programs.
I would say, and I've been doing a little bit of work on this, and so in the method of full disclosure, I'm the Medicare liaison for the International Association of EMS Chiefs, and we worked with Dr. Straub when he was the CMS medical director, and Dr. Straub's retired now. He's down at Stanford, and so one of the things that we looked at was that, and it all depends on what house you want to play in. So if you want to do this yourself, you have to weigh, like how far do I want to get into the healthcare continuum? Do I want to go from being a transport provider to being a medical services provider and everything that may entail? Am I going to have to forfeit my CLIA waiver? What are the benchmarks I have to meet for the PPACA? Or realistically, is the better choice for us to look at a collaborative governance model where we partner with healthcare systems? This is a service that's provided by a hospital/healthcare system. Okay, and they hire us to provide the personnel, the technology, and the resources. And the reason why that probably may work better, and this is my opinion, but between talking to a couple of different people, between Blue Cross, Blue Shield, and a few people in the industry, the reason why that works better is that when we start talking about CMS and modalities for reimbursement, we can leverage things that aren't available to us in the pre-hospital care realm. So one of the things would be, facilities cost, which is pretty much off hands to us. We could leverage the administrative cost for Medicare. Every time we when we start to develop protocols, we have clinical pathways, and we have medical oversight. There's a home visit cost that we can't access now because we're a transport provider, but through the hospital or through the healthcare system, we can leverage those costs. And we really, the gentleman on the end, I'm sorry, I didn't get I don't remember his name right now, but he's absolutely right. We shouldn't approach this with the idea that this is a revenue generator. We need to approach this with the mindset and with the purpose that we're providing a needed service, a valued service to the community. On the healthcare side, what we have to be cognizant of is that when they start moving more toward capitated systems of care and reimbursement, it's important for us to have a really small footprint and have really good cost controls. And so that partnering with the healthcare system takes a lot of pressure off of us to have things in place like compliance programs, et cetera. The hospital already has that in place. Now we're just going to tag on as their subcontractor. The hospital has a lot of these things in place in regards to CLIA compliance and everything else that we won't even have to touch. And it makes it's a lower bar and it's a lower threshold for us. But I'm sure Matt's going to cover all that.
BJ from the California Hospital Association, and I just want to reiterate Sandra's comments this morning about how grateful and thankful we are that you all are embarking on this, and we want to be your partners in crime, if you will. We are all here for a healthier society, an optimally healthy society, and despite all odds, we're going to find it. We're going to get there somehow. We're going to have lots of barriers and lots of obstacles. And I think I've worked with everyone on the panel. However, I also want to reiterate that there are gaps still between you and hospitals. Hospitals are big organizations. There's a lot going on with our transformation relative to healthcare and illness care. And I just want to let you know that we are here to support you in whatever way we can. So my question really is, are there other things that hospitals can be doing to support you? And Miranda, I want to thank you because I had the opportunity to come visit your fine work and connected you to one of our regional vice presidents so we could kind of try to figure out how you could get more exposure in one of the hospitals that you're working at. So that was one example of, maybe there's other things that we can do to support your work, sort of boots on the ground. But I'll just ask all of you if there's any other opportunities in your practices that you've been doing that hospitals can help you more with.
Well, solid data from on the hospital side, and the other thing too is, and this is really important. One of my previous hats, I was on a healthcare cost containment work group in the city of Oakland, and one of the big issues is that it doesn't make a difference what hospital or healthcare system you talk about. Nobody really has an idea of their costs. And if they turn around and you take your costs off your charge master, I mean, even if you talk to somebody at CMS, they know like the charge master is kind of like a made-up number. So I think if you had a really good, robust idea of cost, then it puts a better idea of how much money we're truly saving for the system. And maybe like some type of time-based cost accounting methodology, where you take your actual costs for, for your individual providers, RNs, et cetera, and then their time-based activity. A time-based costing activity model is probably the best. KPMG has a lot of stuff on that. Well, it's not Arthur Andersen anymore. It's Agilent, I think. But, there are a lot of robust models there. Medicare has a really good model. But, having an idea, because for us, our costs are kind of simple on the EMS side. And so what it costs for us to field an ambulance, what it costs for us to staff personnel, it's easy to figure out. But then if I come to you and you ask me, like, how much money am I really saving you? Well, if I go off the charge master, I know that's really not a good number. But if you had something better, that would help us flesh it out.
Two hopefully quick questions. One is, emergency physicians are moving toward a lot more to observation medicine as an approach to reducing readmissions. I was just at an ACEP conference last week where 2 days spent on doing nothing but trying to avoid readmissions by putting people in observation centers for 24 hours. I guess one question I have is, did you guys work with any hospitals that were using that model, and did community paramedics, rather than rounding on discharge from the inpatient service, were you invited into that aspect of observation medicine? Because I think that's really an arena that is going to be a real opportunity for us. And just on the question of hospitals, did you encounter any opposition to the idea of sharing information? In other words, did you encounter any situations where the hospitals didn't want to treat your community paramedic as a partner? Were HIPAA issues dissolved, or were there issues of trust there that still need to be worked on? Thanks.
Yeah, the HIPAA issues aren't really an issue with us anyway up at Enloe. And the documentation that we do with from the community paramedic in, from both the phone calls and the home visits, are uploaded into the medical record of the patient. So our hospitalists and the emergency room physician, if they do come back to the ER or are readmitted, have access to those records that the community paramedics have already input in there, so they can see that continuum of care from their post-discharge till their readmission, what has gone on between there and how the patient was actually feeling in there. So that's kind of helped. But as far as the ER docs go, at least our ER physicians to treat and street or admit to hospitalist and find a specialist from there.